Hello everyone, welcome to Dermready Lectures. In today's class, we are going to discuss about an important topic in psychodermatology, that is psychogenic pruritus or functional itch disorder. Imagine, imagine a patient comes to you with complaint of generalized itching since last 3 years. There are no any skin lesions, no any systemic causes, no any other organic causes of pruritus. Then how do you deal with it? Let's start the presentation. So what are you missing? Similar case report. A 34-year-old woman presents with generalized itching for 8 months. Skin exam is completely normal, right? We did a workup. Skin biopsy, unremarkable. CBC, LFTs, RFTs, normal. TSS is normal. Fasting blood sugar, normal. Chest x-ray, normal. HIV, hepatitis B, C, negative. All the workup that suggests the systemic causes of the pruritus is normal. She has already visited 3 dermatologists, 2 allergists, and countless creams. No diagnosis, no relief. How to approach the case? What is the case? If there is exclusion of all the causes of the pruritus, there is no any apparent causes of pruritus, but the patient still complains of pruritus, then how do we approach? We think for the psychogenic disorder, psychogenic pruritus, or functional itch disorder. So, what is psychogenic pruritus? Definition: an itch disorder where the sensation is central to the symptomatology and psychological factors play an evident role in its triggering, intensity, or persistence. Key insight is it is the category of the chronic itch that is lasting for more than 6 weeks that originates in the brain rather than the skin. So, it is the brain that itches, not the skin. Talking about the clinical burden of psychogenic pruritus, estimated to affect approximately about 6.5% of dermatology outpatients, which is a significant percentage. Quality of life impact is comparable to chronic pain or nausea, with 60% of the patients reporting significant limitations in daily life. It is associated with many psychiatric comorbidities like depression, anxiety, suicidal ideation, sometimes delusion of parasitosis, and other psychiatric conditions. Let's talk about the cause or the pathophysiology of the psychogenic pruritus, which is interesting one. So, the central nervous system is the origin of the itch. In skin, usually the origin of the pruritus is caused by histamine, but in this case, the central nervous system is the origin of the itch, the brain itch. Unlike dermatological itch, psychogenic itch originates in the brain. Perception of the sensory requires complex cooperation of sensory, motor, and affected areas, with the precuneus playing a specific significant role in the perception of the itch. Precuneus is the part of the parietal lobe. This blue part, brain here, is the precuneus, and it plays an important role in the perception of itch. Another is the neural circuitry and emotion. Do we feel pruritus when we are emotionally unstable, or does our emotion have a role in causing the pruritus? So, and overactive limbic system, particularly the anterior cingulate cortex, it modulates the emotional and cognitive aspects of the itch. So these two parts, they help in the emotional part of the itch. The prefrontal cortex also interacts with the limbic system. So the prefrontal cortex of our brain also interacts with the limbic system here, influencing the motivation behind the urge to scratch. So there is an urge to scratch as we have studied in the itch scratch cycle. So our prefrontal cortex that communicates with the limbic system for the itch. Reward and addiction vicious cycles. We all know that itching is rewarding. So whenever we scratch, there is certain rewarding, which makes it addictive. So scratching, it activates the midbrain reward circuits. Here, dopamine and opioids, two neurotransmitters, they play an important role. These opioids, they create pleasurable sensation, and this dopamine, they make it addictive during the scratching that leads to an addictive self-perpetuating each scratch cycle. you know in the cutaneous causes of the pruritus, usually histamine has an important role, but in case of psychogenic pruritus, these opioids and dopamine, they have a very important role. Stress induced hypersensitivity, so stress can also lead to the psychogenic pruritus. It triggers the hypothalamic pituitary axis, which releases mediators like beta 2 adrenoreceptors, which induce pro-inflammatory mediators like TNF alpha in the skin. And this TNF alpha, it lowers the itch threshold and explains why psychological distress directly aggravates the physical sensations. Because of the increase in the pro-inflammatory mediators which reduce the threshold for itching, it causes itching. Then another mechanism for psychogenic is the deficient gate control. Not all the sensations that come inside our body are perceived as the itch sensation when we are normal. But in case of psychogenic itch, there is hypothesized failure of the brain's gate control mechanism. Instead of inhibiting or selecting bodily signals, our deficient gate amplifies them, causing the patient to perceive itch from signals that a healthy brain that will ignore. Then sensitization and nerve hyperplasia. In case of chronic itch, it causes peripheral and central sensitization. That means our central nervous system and the peripheral nervous system, they are more sensitive to the itch sensation. They are more sensitive to any stimuli that triggers itch. This process involves the release of inflammatory mediators and even nerve hyperplasia, increase in the density of the nerve in the skin, making the area increasingly sensitive to any touch or stimulus in case of the chronic itch. And psychogenic itch are usually the chronic itch. Contagious itch and mirror neurons. Have you ever experienced in OPD that while checking the patients who have been itching their skin, we also feel an urge to scratch? Sometimes we also feel pruritus. So this is contagious itch. And mirror neurons, they play an important role in contagious itch. This can be mentally induced purely by visual or auditory stimuli, such as lecture. Even while I'm teasing about pruritus, some of the people may feel urge to itch. This is believed to involve human mirror neurons. These human mirror neurons, they are more active in the chronic itch patients and individuals with neurotic personalities. What are the key neurotransmitters that are responsible for the psychogenic itch? In contrast to the cutaneous causes of the itch, hypersensitivity causes of the itch, where histamine plays an important role, psychogenic pruritus often involves opioids, acetylcholines, and dopamine, which are central to the mental induction and emotional reinforcement of the sensation. This dopamine, it makes it addictive. It is involved in the reward system and the urge to scratch more. You might have seen a case of lichen simplex chronicus where the patients keep itching and itching, where the patients keep scratching and scratching because they have the itching sensation in their skin, and it's very rewarding for them when they scratch the area what that is itching. Here the neurotransmitter dopamine plays a very important role. So what are the diagnostic criteria for the psychogenic pruritus? So there are two types of criteria. One is compulsory criteria, another is optional criteria. In compulsory criteria, all three should be met. The compulsory criteria are localized or generalized pruritus without primary skin lesions, chronic pruritus lasting more than 6 weeks, and absence of an identifiable somatic cause. The optional criteria Out of 7, more than 3 should be required to be diagnosed as the psychogenic pruritus. Here, chronological relationship with the psychological life event should be there. There should be a temporal relationship between any life event, that is psychological illness or event, and there is the pruritus. Intensity variations associated with the stress, nocturnal variation in the pruritus, usually pruritus during night time or during rest or inactivity, presence of and associated psychological disorders, improvement with psychotropic medications, and improvement with psychotherapy. If all three compulsory area are met and three or more optional criteria are met, then this is diagnosed as the psychogenic pruritus according to French psychodermatology group, FPDC. Another is the butterfly clue to diagnosis. In case of psychogenic pruritus, there is a butterfly shaped area that is speared in the back where the patient's hand can't reach. So this is usually during the psychogenic pruritus. Now, what are the differentials? It's very important to differentials. Functional is disorder or psychogenic pruritus are diagnosed using the French psychodermatology group criteria, as you have already discussed, but we also exclude other things also. For diagnosing it as a psychogenic pruritus, this FPDZ criteria must be met. Neuropathic itch, it may mimic the functional itch disorder, but is often accompanied by pain, burning, allodynia, paresthesia, or electric shock-like sensations, suggesting nerve injury or dysfunction. There are self-inflicted skin lesions like in dermatitis artifacta, where the primary problem is self-inflicted scratching or skin manipulation. In functional itch disorder, the primary complaint is the sensation of itch, with the skin lesions occurring secondary to the scratching. Do you understand? Though, in case of dermatitis artifacta, it is initially there is self-inflicted scratching or skin manipulation without any urge to scratch. And psychogenic pruritus has a lot of misdiagnostic risk because we should not primarily label chronic itch as psychogenic or idiopathic. We should always exclude the underlying dermatological, neurologic, and systemic diseases like Hodgkin's lymphoma, cholestatic liver disease, chronic kidney disease, which present with generalized pruritus. We must exclude all these conditions and then check whether it meets the French psychodermatology group criteria or not. If it meets, then it is functional itch disorder. How do we manage the functional itch disorder? So first is the skin care. If there is any lesion in the skin due to the pruritus, then we manage the skin lesions with emollients and humectants, with soap substitutes and bath additives, cooling creams, menthol in aqueous cream, which provide relief from the itching. And we should also treat the associated skin lesions with the pruritus, like for which we can use topical corticosteroids or other topical anti-inflammatory agents if coexisting dermatitis is present. Then symptomatic relief. For symptomatic relief, we can use antihistaminic. Usually sedating antihistaminic is more effective for nocturnal itch, like hydroxyzine. And it's very important to manage the psychiatric condition that is associated with the psychogenic itch. Psychological management includes behavior-oriented therapy or habit reversal therapy. The second line drugs are tricyclic antidepressants, especially the doxepin, because it has very good antihistaminic property as well, along with the tricyclic antidepressant property. Then amitriptyline, we can use selective serotonin receptor inhibitors like fluoxetine, citalopram, and other modalities of treatment are phototherapy and photochemotherapy for refractory itch. Then the third line are other antidepressants like trazodone, duloxetine, topiramate, serlopitant, and naltrexone, which is opioid antagonist. Then the emerging therapies are the biologics like nemolizumab, which is anti-interleukin 31 receptor antagonist. Then dupilumab, interleukin 4/13 monoclonal antibody, JAK inhibitors like baricitinib and upadacitinib. Biologics and JAK inhibitors remain emerging options and are generally considered after failure of the conventional systemic therapy or when these are contraindicated. So this is the summary of the first line, second line, and third line management for psychogenic pruritus. So thank you for listening. It is very important to understand about psychogenic pruritus since many patients might have psychogenic pruritus, may go undiagnosed. And another important thing is like to exclude all the systemic causes before labeling it as a psychogenic pruritus, because there always risks, there always remains risks of misdiagnosis of such condition. So if you find this presentation useful, please share it with your friends and subscribe my channel. We'll be discussing about many important dermatological topics in Dermready Lectures. Thank you.